ECG manifestations of old myocardial infarction is quite variable. Some small myocardial infarctions leave no sequelae on the ECG after a few years. In anterior infarction, old infarction can manifest as poor progression of R waves. Otherwise, the hallmark of old infarction is the presence of pathological Q waves. ST segment usually is isoelectric but can remain elevated in left ventricular aneurysm and dyskinesia. A dyskinetic segment of myocardium is one which bulges out in systole instead of contracting and moving inwards. Persistence of ST segment elevation long after myocardial infarction, usually over 6 months, was considered a surrogate sign of left ventricular aneurysm in the era when easy access to imaging like echocardiography was not available. Sometimes ST segment depression may be noted due to associated left ventricular hypertrophy or even due to transient ischemia in another territory at the time of recording. T waves which are inverted in recent infarctions may become upright as time passes but may remain inverted for a variable period of time, especially in large infarctions of the anterior wall. In an old infarction with significant left ventricular dysfunction, left atrial overload pattern may be noted due to dilatation of left atrium. This ECG shows sinus rhythm at around 75 per minute with pathological Q waves in inferior leads indicating old inferior wall myocardial infarction. Pathological Q waves are usually 40 millisecond in width and have an amplitude of more than 25% of the ensuing R wave. T waves are inverted along with pathological Q waves in leads 3 and AVF. R wave voltage is high in V5 and V6 indicating left ventricular hypertrophy. The presence of mild ST segment depression in lateral leads may indicate fresh ischemia. If the ST segment depression was due to LVH, it would have been downsloping associated with T wave inversion, that is LVH strain pattern. Here it is almost horizontal ST segment depression which is usual with acute ischemia. Tall T waves in V4 to V6 can occur due to any of the following: ischemia, hyperkalemia, or left ventricular volume overload. But tall T waves in V2 and V3 in which the predominant QRS is negative is unlikely to be due to left ventricular overload, in which it is usually in leads with tall R waves. In this case, it is more likely to be a manifestation of ischemia as indicated by the associated plain ST segment depression. In left ventricular volume overload, the ST segment usually shows a mild concave upwards ST segment elevation. The commonest finding on electrocardiogram in pulmonary embolism is sinus tachycardia. Pulmonary embolism can occur without significant ECG abnormalities. ECG may show right ventricular ischemia, T wave inversion in leads V1 to V3, incomplete right bundle branch block pattern, or S1 Q3 T3 pattern, S waves in lead 1, Q waves and T inversion in lead 3. T inversion in inferior leads can also occur in pulmonary embolism. Right axis deviation is another important feature of pulmonary embolism, which is also indicated by the S waves in lead 1 in the S1 Q3 T3 pattern. Both the anterior T wave inversion and incomplete right bundle branch block pattern are indicative of the acute right ventricular overload due to obstruction of the pulmonary circulation. ECG changes of acute right ventricular volume overload resolves rapidly with the resolution of pulmonary embolism by treatment and may return to near normal levels as the pulmonary arterial pressure normalizes. Similar ECG findings can also occur rarely in other causes of acute cor pulmonale with right ventricular overload like a major lobar collapse. Massive pulmonary embolism is also one of the causes of pulseless electrical activity. Pulseless electrical activity refers to any cardiac rhythm in which there is no palpable pulse but the ECG shows cardiac activity. The earlier terminologies for pulseless electrical activity were electromechanical dissociation and non-perfusing rhythm. It is due to the inability of the heart to generate sufficient force of contraction in response to depolarization. S1Q3T3 pattern in ECG is seen in acute pulmonary embolism. S1Q3T3 pattern means the presence of an S wave in lead 1 indicating a rightward shift of QRS axis with Q wave and T inversion in lead 3. S1Q3T3 pattern is the classical ECG pattern of acute pulmonary embolism, which is often taught in ECG classes, though it is not the commonest ECG finding in pulmonary embolism. The same pattern can also occur in other cases of acute carpulmonale. The commonest ECG finding in acute pulmonary embolism is sinus tachycardia, which is noted in this ECG as well. T-wave inversion in anterior leads is another finding in pulmonary embolism. Serum potassium levels below 3.5 milliequivalent per liter is considered as hypokalemia. Hypokalemia can occur due to gastrointestinal or renal potassium loss or due to shift from extracellular to intracellular compartment as occurs in alkalosis. Myocardium is very sensitive to the effects of hypokalemia, which may be exacerbated in the presence of ischemia or digoxin toxicity. Electrocardiographic changes are an important feature of hypokalemia. As the serum potassium levels fall, the T waves may become flattened and may disappear. The U wave becomes more prominent as the hypokalemia worsens. This in effect will produce an apparent QT prolongation, though it is actually the QU interval which is often manifest. Prolongation of action potential duration in hypokalemia is due to inhibition of the outward potassium current. IKR, the rapid component of the delayed rectifier potassium current, is markedly depressed in hypokalemia. There is rapid inactivation of IKR during repolarization. Downregulation of IKR occurs in chronic hypokalemia. In addition, chronic hypokalemia causes internalization of IKR channels, reducing their surface density on the plasma membrane. Prolongation of action potential duration with hypokalemia increases the chance of ventricular arrhythmias by potentiating after depolarization. When the after depolarizations reach a threshold value, they trigger a ventricular ectopic beat which can induce sustained ventricular arrhythmias in this setting. Shortened effective refractory period is another reason for arrhythmias in hypokalemia. Even though the action potential duration is prolonged in hypokalemia, there is no corresponding lengthening of refractory period. This predisposes to perpetuation of arrhythmia induced by the after depolarizations. Hypokalemia slows the conduction in the AV node by potentiating the effect of acetylcholine on suppressing the atrioventricular conduction. Hypokalemia-induced membrane hyperpolarization is thought to have a role in this negative dromotropic effect. Hypomagnesemia seldom occurs in an isolated situation, so that it is difficult to document ECG changes in isolated hypomagnesemia. It is often associated with other electrolyte imbalances like hypokalemia and hypocalcemia, which confound the ECG changes. Nevertheless, there have been case reports of isolated hypomagnesemia with ECG changes. Tsai and colleagues in their report of isolated hypomagnesemia noted global T-wave inversions and prolonged QTC. The person had history of heavy alcohol use and presented with syncope. There was no associated hypokalemia or hypocalcemia. ECG resolved after correction of hypomagnesemia, which was initially at 1.1 mg per deciliter. Coronary angiography did not reveal any obstructive coronary artery disease in him. Magnesium is an important cofactor for adenosine triphosphate powered processes in the body, including renal potassium reabsorption. That is why hypomagnesemia seldom occurs in isolation and is almost invariably associated with renal potassium loss and hypokalemia. 95% of body magnesium is intracellular, and serum magnesium levels are a poor indicator of total body magnesium level. Both the sodium-potassium pump and calcium pump need magnesium as a cofactor. Magnesium acts as a physiological calcium antagonist in the myocardial cell, with low magnesium levels causing calcium release from sarcoplasmic reticulum and high levels blocking this. It is well known that toss at the point or polymorphic ventricular tachycardia in the setting of QT interval prolongation responds to magnesium infusion. This suppression of toss at the point is due to blockade of L-type calcium channels by magnesium, and tossats get controlled even without shortening of the prolonged QT interval. The effect of hypomagnesemia on cardiac arrhythmias is thought to be related to the impairment of sodium-potassium ATPase in the cell membrane involved in the transmembrane transport of sodium and potassium. All sorts of cardiac arrhythmias have been described in the setting of hypomagnesemia, but it is not clear how much is the actual contribution of hypomagnesemia, as it is often associated with other electrolyte abnormalities like hypokalemia. Prolongation of ST segment contributing to prolonged QT interval and corrected QT interval is the hallmark ECG change in hypocalcemia. Hypocalcemia prolongs phase 2 of the myocardial action potential, thereby prolonging the ST segment. T waves are not generally affected in hypocalcemia because phase 3 of the myocardial action potential is not affected by calcium ions. Calcium channels close at the end of phase 2, with phase 3 being mostly related to potassium channel activity. Associated electrolyte abnormalities can alter the ECG findings of hypocalcemia, as occurs in renal failure, in which hypocalcemia is often associated with hyperkalemia. Yet, intravenous calcium, which is often given for treatment of hyperkalemia in acute renal failure, is useful in the treatment of associated hypocalcemia as well. ECG showing ST prolongation in hypocalcemia. ST prolongation as a cause of QT interval prolongation is less common than other mechanisms of QT prolongation. ST segment roughly corresponds to the phase 2 of myocardial action potential, and ST prolongation without QRS widening or T-wave widening is classical of hypocalcemia. The classical ECG change in hyperkalemia is tall, tended T waves. As the severity of hyperkalemia increases, the QRS complex widens, and the merging together of the widened QRS complex and the T wave produces the sine wave pattern of severe hyperkalemia. But the levels at which ECG changes are seen are quite variable from person to person. IKR, the potassium current responsible for potassium efflux during repolarization, is sensitive to extracellular potassium levels. Function of IKR increases with hyperkalemia, increasing the potassium conductance in phase 2 and 3 of the action potential. This leads to faster and shorter repolarization, manifest in surface ECG as tall peaked T waves, the reciprocal of what occurs in hypokalemia. In severe hyperkalemia, there is absence of P waves, sometimes referred to as atrial paralysis. At the same time, sinus node still controls the ventricular rhythm, and this is known as sinoventricular conduction. This is because sinus node is thought to be more resistant to the effect of hyperkalemia than the atrial tissue. Theoretically, the existence of sinus node activity controlling the ventricular rhythm in the absence of P waves can be inferred from the respiratory sinus arrhythmia, inspiratory increase and expiratory decrease in the heart rate. In this ECG, some features due to hyperkalemia are visible. 1. Tall T waves. T waves in anterior leads are as tall as or taller than the QRS complexes, though the absolute amplitudes are not very high. Typical description in hyperkalemia is tall tended T waves. 2. QRS widening with right bundle branch block light pattern. 3. Lack of atrial electrical activity. No P waves are visible and there is bradycardia. It could very well be a slow junctional rhythm. Ideally, if there was sinus arrhythmia visible in the QRS complex intervals, one could have presumed that there is sinus node activity with atrial paralysis and sinoventricular conduction. ST segment shortens when the serum calcium, or specifically the level of ionized calcium, rises. This leads to shortening of the QT interval in hypercalcemia. In severe hypercalcemia, the shortening of ST segment is so much that it appears to be almost absent, and T wave starts almost at the end of the QRS complex.